All right, it's 10:01, and I think that we could get started. Welcome, everyone, to ReelDx Classroom. We are incredibly delighted. I'm Dr. David Spiro. I'm the Chief Medical Officer and co-founder of ReelDx, and incredibly delighted to present Dr. Chris Behringer, who's the Chief Medical Education Officer at Heal Clinical Education. He is a family physician and incredibly excited to and an outstanding educator. We've had a chance to work with him over the last bit, and he is just outstanding and incredibly excited to have him lead the discussion around case number 322, which is around rectal bleeding and abdominal pain. So welcome, Chris, and thank you for your time in presenting ReelDx Classroom today.
Absolutely. Thanks for having me. Yeah, so my name is Dr. Christopher Behringer. I'm board certified family medicine physician, practice out of the state of Kentucky. I did my undergrad in microbiology and biotechnology at the University of Central Florida and did my medical school at the Lake Erie College of Osteopathic Medicine. So I am a DO, and I did my residency in North Carolina. I've also done a little bit of training in acupuncture in China. And I guess an interesting fact about me is I was born and raised in Saudi Arabia, and I lived there for 19 years. My parents worked for the oil company. I've been lucky enough to go back towards there and kind of talk about, bringing standardized medical care to other regions. There's a Johns Hopkins facility out there, so it's been cool. Anyway, this is going to be a fun case. So we're going to be taking a look at this gentleman here who comes in with rectal bleeding and abdominal pain. And the objectives for today are going to be, let me get my
While we're waiting for the next slide, just so everyone knows, this is going to be incredibly interactive. So I see everyone who's listed here so far today. We want you all to be asking questions throughout the engagement. So please ask questions. We'll answer them as they come up.
Absolutely, and I'll be asking all of you guys questions. So we'll see what I can get out of y'all. Anyway, so today we're going to learn some of the most common causes of GI bleeds, both reported and unreported, some of the different presentations of different GI bleeds, and understand kind of the workup and management of different GI bleeds, but we'll be focusing more on some of the more common presentations that you all will see as clinicians. This is something that you'll see both in outpatient as well as in ERs and inpatient, and affects, men, women, people of all different ages and stuff. But let's go ahead and get rocking and rolling with our patient video here. So before we get started, one thing I do want to show off here is we have here at the bottom the soap note skill. So all y'all should be able to access this if you scroll down, where you'll be able to write down a soap note. I already kind of templated mine out a little bit. Yours will be a blank text box, but I put down a place for a chief complaint, an old cards template and a basic HPI, as well as physical exam, and some spots here for, different diagnoses and some plans that we're going to do. So go ahead and get that up, because yes.
Just before the video starts, just so everyone knows, all of the video content on the ReelDx site is patients have signed informed consent, and they've given permission, and we're very thankful for all the patients that have allowed themselves to be recorded so we could all learn from this experience. So
yeah, this has been a fantastic experience. I've been able to use this platform to help teach and bring real clinical cases in with undergrads, where I've lectured to hundreds of undergraduate students as well as in person and online. So all right, so for everyone who's here, let's go ahead and get started with the video. So go ahead and get ready to take some notes.
Thank you for letting us interview you. Can you tell us a little bit about what's going on today?
I've had a lot of rectal bleeding the last 4 days. I have severe abdominal pain.
And you have a history of diverticulitis?
Yes.
When was that diagnosed?
4 years ago.
About 4 years ago. And that was diagnosed that you had a colonoscopy?
Yeah. Had 2 of them.
And are you having tummy pain as well?
It's just below there.
Where's your tummy pain?
Just kind of below the right in here.
Can you show us real quick?
Right here.
Right over there?
Right in the center, basically.
Right in the center. So can I just lift this up for a second? Thank you. Can you just point to where your pain is?
Right there.
Right just below? Okay. Can I feel your belly really quickly? Does that hurt over there when I press?
A little.
And how about over here when I press?
Not as much.
Does it hurt more when I press in or when I let go?
On this side, it doesn't seem to matter.
And you're not having that much pain here?
Some.
A little discomfort there? Mm-hmm. And can you quantify how much bleeding you've had? How much blood has come from your...
A lot.
A lot?
In 4 days.
And it's bright red?
It's a mix.
And there's some brown?
Yeah, some real dark black clots today.
Uh-huh, uh-huh. And is the pain worse in your tummy or is it worse in your bottom?
It's worse in my stomach.
Have you had fever? Any vomiting?
No,
Okay. Has the pain ever been this bad before?
not in this spot. No.
And I know your wife is here. Does he seem a bit pale to you?
A little bit, yeah.
Mm-hmm, mm-hmm.
Having a rough time.
Thank you for letting us take this video.
Welcome.
All right. So here we have, a gentleman coming in with he's looking pretty uncomfortable here. Now, I understand most of y'all here are, students getting ready to go into being a PA and everything. David, is it okay if I kind of just call on people and allow them to talk?
Please.
All righty then. I'm just going to go in order that I see them. So if I pick on you, it's just because that's the order I see you in. All right. Miss Danielle Tran, go ahead and tell me, you've probably been introduced to a SOAP note format and as well as an old cards format. Go ahead and tell me, what did our patient come in for?
Rectal bleeding for 4 days.
Good. Awesome. And he mentioned abdominal pain. Where would you say his abdominal pain is located?
Under, or like periumbilical.
Periumbilical, we might be able to call it suprapubic as well for him. Now here's a question. When a patient comes in with, a diverticulitis case, where does that generally affect people? Which quadrant or which part of the colon, do you know?
The lower left quadrant.
Lower left quadrant. So, we're kind of looking at this and be like, okay, maybe a little bit, not quite where we would expect it to be. All right. Did he characterize his pain at all?
Not really.
No, he didn't characterize his pain, but how did he describe his stool?
As a bright red mixture of colors. He did notice some dark black clots.
Right, which would be pretty much hematochezia and melena, which would be, terms we could use. But yeah, bright red blood per rectum as well as melena. All right.
Chris, can you just share with me the paradigm you're using, LDCAA?
Yeah, this is old carts onset. So old carts is just an acronym. So each of them is onset, location, duration, characterization, associated / aggravating, relieving, temporal, and severity. So onset, when did your symptoms start? Location, if you have pain, where are your symptoms located? Duration, if your symptoms are episodic, how long does each episode last? Characterize, if it's pain, is it sharp, is it dull, is it achy? If you're having a cough, is it productive, non-productive? Diarrhea, is it loose, is it bloody? Aggravating, does anything make your symptoms worse? Associated, do you have anything with your symptoms such as fever, nausea, etc. with your symptoms? Or if you have a headache, do you have numbness, do you have vision changes? Relieving, did you try anything that makes this better? Pain medicine, rest, sleeping. Temporal is somewhat related to onset or duration, but it's more, hey, if I get recurrent episodes of symptoms, do they happen regularly at the same time? They always happen first thing in the morning. Now, I've been having this pain in my foot every morning, and it's always the first step in the morning. And then severity is your scale of 1 to 10, 0 out of 10 pain, or you could qualify it. You could say, how debilitating is this? Does it affect your ADLs?
Thank you.
Oh, hold on. I'm not asking you to unmute there, Daniel. I'm just removing your permission to talk because I'm going to pick on someone else now. All right. Dara, I would go ahead and let you in. Did he mention anything that went along with his rectal bleeding? If you're not able to talk, just let me know. Or All right, gonna move on. Hiba, Shakir, are you able to talk? All right. I'll go ahead and move on here. So he does report some abdominal pain for him, but he didn't really necessarily talk about, no nausea, didn't mention any vomiting or anything like that. He was really just complaining about the rectal bleeding as well as the abdominal pain for him. He didn't mention any aggravating factors for him. And we didn't really ask him, hey, did anything make it better? Did we give him any pain medicine? Did he try anything at home? Did he try, did he try taking like some Tums, or did he try taking some Pepto-Bismol? He didn't really mention anything. And then temporal and severity, same thing for this guy. We didn't quantify his pain, but you could kind of qualify his pain just a little bit, or at least his discomfort, because he looks very, very uncomfortable there in the bed. All right. So I'm going to go ahead and pick on someone here. Jeff Hartz, if you were to see this patient in the clinic or in the emergency room, and I sent you in to talk to this patient, how would you present this patient to me?
All right, sorry, it took me a second to unmute. I think I'd focus on the symptoms that we talked about, including how he described his stools and the pain being the worst he's experienced, at least at this location, and also his past history of diverticulitis.
Awesome. Yeah, go ahead and present the patient to me. You went and talked to the patient. I said, hey, what's going on in bed 4?
So we have a middle-aged male history of diverticulitis that was diagnosed by colonoscopy a couple of years ago. He's having lower abdominal pain and bloody stools, describes it as some bright red, some dark clots, and says it's as significant a pain as he's experienced in this area of his body.
Awesome. Yeah, so in terms of his physical exam that we could see, Jeff, how would you describe his general appearance?
He looked pale, and he seemed like he was, did clearly appear to be in pain, was kind of wincing and breathing normally, but maybe struggling to communicate a little bit just because of his discomfort.
Good. And what would you say about his abdominal exam, at least from palpation that we could see?
Was it his left side a little more severe pain than right side palpation?
I think so. It looked like his left side was just maybe a little bit more tender, or more kind of that I think it was his right side. When he pushed down, looked like that. If I remember correctly, that was more on his right side. Okay. It was a little bit more tender. But what's a pertinent negative on his exam? When the physician examined and said, hey, if I push in really deep or if I let go, which is more tender? What's that called?
Sorry, I don't know that.
That's called rebound tenderness. So that's called a peritoneal sign. That would be similar. That would be, more indicative of something like a perforation or something that's more severe. So peritoneal signs are more when you kind of release pressure from something. So you can say he's like, mild to moderate, moderate tenderness to palpation, right lower quadrant, but no rebound tenderness. And another thing is no involuntary guarding. So he's letting you touch him. That's a big thing. That's another peritoneal sign to see, how severe is this guy's pain, or how severe is his abdominal pain? Does he even let you touch him, or is he involuntarily contracting and, having some kind of almost not even thinking about it, guarding himself from the pain? So there's some things. Awesome.
And I would just say, I'm a pediatric ER physician, so this is way out of my area, but because this is an adult. But the fact that Chris is focusing on peritoneal or non-peritoneal pain is very important, because if it's peritoneal pain, if you have guarding, if you have some of these signs that Dr. Behringer is talking about, then you start to think about something that is concerning that might even be surgical, such as appendicitis or bleeding into the peritoneal space. There's irritation or inflammation of the peritoneal space And that would raise your concern about the severity or perhaps that there may be, this may warrant a surgical intervention or at least a surgical consultation. So.
Absolutely. Peritoneal signs are bad news bears. Those are, if you find a peritoneal sign, that's something you call the surgeon, you tell them, say, hey, I've got this guy with this physical exam findings. Because the imaging might be not terribly impressive, but saying I've got these peritoneal signs makes surgeons sit up straighter. Alrighty then. So now that we have a basic history and a presentation on our patient, let's go ahead and move on to looking at things like vitals and his demographics. Jeff, I'm going to go ahead and just move you back into the regular room here. All right, so we have a 51-year-old male, looks like good weight, good height, and everything like that. So I'm going to unmute Maria here. Maria, are you able to talk for us?
Can you hear me?
Yes, we can hear you. Tell me about these vitals. Is there anything here that makes you worried?
Well, the blood pressure is a little low. His heart rate is okay. Respiratory rate's good. Pulse ox is good. He doesn't have a temperature, so that's good. I would say, the blood pressure could be a little low.
All right. What if I told you that's my blood pressure sitting here right now?
Well, then I would say that the blood pressure is okay.
Yeah, so now this is a thing where we start taking a look at multiple vital signs combined, because what are we worried about that blood pressure with his bleeding?
Well, we're worried he's losing a lot of blood.
Right, so what would the heart rate do if his blood pressure was truly unstable low?
It would be high.
It would be high, correct. So that's something to look at with this guy is like, hey, that blood pressure does seem a little bit low. Our threshold for kind of quote unquote low is going to be closer to a systolic of 90. I do a lot of powerlifting and kickboxing. I sit around, 100 to 110. That's my usual blood pressure. So 90 is a good number to kind of sit around and have as your red flag, sort of like we have 140 as our red flag for, essential hypertension and 180 for hypertensive emergency or urgency in a patient. So seeing 108, maybe he usually sits at around 150 and that actually is hypotensive for him, but that heart rate of 57, at the very least, he's not losing enough blood to get a physiologic response out of him. All right. So fantastic. Thank you very much. Thank you very much, Maria. So one thing I definitely want to kind of hammer home for a lot of people with this is looking at these vital signs. I'm going to bring someone else in here. Michelle, I'm going to bring you in and I'm going to ask you a question I like to ask everyone. All right. Michelle, are you able to talk for us? All right, how about Jasmine?
Hi, yes.
All right, you're able to talk for us. All right, let's go ahead and ask you a question here. So I'm going to ask you a question about vital signs and what am I more concerned about? The general question goes like this. Am I going to be more concerned about vital signs that are high or low? So for example, I'm going to go a certain number either direction. So you have a patient with a normal temperature of around 98. Am I going to be more concerned of a person coming in with 102 or 94? Am I going to be more concerned of a blood pressure, say 120, let's go up 40 and down 40, 160 or 80? Which do you think I'm going to be a little bit more concerned about with these?
Gosh, maybe if we were worried about like a diverticulitis, maybe a higher temperature. But a hypothermic patient, we should also be concerned about if, what if it's less than like 36 degrees?
Good.
Yeah.
All right. What about heart rate? Average heart rate being around 80. Am I more concerned about someone coming in, sick with 120 or 40? You're moving 40 in either direction.
Yeah, I would say if it's upwards in the 140 range, that's definitely more concerning than 120. I think someone who's like kind of small and has a hummingbird heart like mine, I kind of live at this 100 range. But I would say like a 120 or 140 is more concerning to me as well. However, I know a lot of people, if they were bradycardic, people just kind of also live at a lower heart rate. So I feel like maybe a less lower heart rate's less concerning.
Okay. So in general, and this has been in my clinical experience and things like that, is that lower numbers are generally going to be worse off than higher numbers. There's kind of a reason for that. Now, there are some people who live at a heart rate of 40, like Lance Armstrong, who's a super athlete, but most people are not Lance Armstrong or super athletes. So the thing a lot of us as clinicians should remember is that fevers are compensatory mechanisms. High heart rates are to try and increase perfusion to areas. Same for higher blood pressures. We're trying to increase perfusion. These are your body's compensatory mechanisms. You can see a person walk around with a blood pressure of 180 for months undiagnosed. People with AFib can go around and just be fairly asymptomatic for a long time. And then remember, a fever is our body's natural defense mechanism. And we can work with that. As clinicians, we can look at ourselves as, we don't really fix anything in the human body. We instead just provide the body an optimal environment to do its best healing. We walk around 99% of the time healthy. And so our body has really good self-healing, self-maintaining properties to it. And so we just kind of give support, antibiotics, fluids, things like that. The problem when things get super low is, guess what? I start having to replace things. I start having to be the body. I start having to vent you, pace you, give you pressors, things like that. Because one thing I like to tell people is that, hey, blood pressure of a dead person is 0, heart rate of a dead person is 0, and respiratory rate of a dead person is 0, and temperature is room temperature. So the closer we get to those things, the more concerned I'm more concerned about your natural mechanisms have failed, and the more I'm concerned that I have to be your body, which is never a good place to be. All right, so that's just a little teaching point I like to kind of nail out of the way for the purposes of everything. All right, so next. We've got this guy who's coming in. Vital signs look pretty much okay. I'm not concerned necessarily. If he does have an infection, I'm not necessarily concerned about any kind of septic picture because he doesn't meet any of the criteria, such as having a high temperature, a high heart rate, etc. I'm not too worried about hemodynamic instability because we don't see that reflex in the heart rate. So good, we've kind of got time. When I worked in the ER, I was always taught to take a look at patients as, what's going to kill my patient in 5 seconds, 5 minutes, 5 hours, 5 days, 5 weeks, 5 months, 5 years, and then 5 decades. That's a great way of looking at your patients and trying to work through diagnoses and saying, what do I need to do right now? Looking at his previous medical history, we see that he had diverticulosis and diverticulitis. He has a history of angina, PTSD, some of the things here that aren't terribly as concerning, but I'm going to go ahead and unmute Jenny here because I'm going to go ahead and start asking this question. Jenny, are you able to speak?
Yes, I am.
Give me a few, what do you think your top diagnoses are for this guy? I want at least 10 from a combination of you guys. You yourself do not need to come up with 10, but give me as many as you can.
To be honest, I don't know. I'm not a healthcare professional, so I'm just kind of listening in today for education purposes, but
oh, okay.
I'm sorry,
totally
I don't
fine.
know.
Oh, that's totally fine. All right. What did he have a couple years ago?
Yeah, so his history was diverticulitis or diverticulosis.
There you go. All right. That's what I'm going to give you. You put down diverticulitis. You got the low hanging fruit because why not? I mean, that's what he had a couple years ago. What's wrong with that? All right. I'll put you back in the room. I'll try to remember not to call on you. I'm coming back to Maria. Maria, do you have any diagnoses for me?
How about ulcerative colitis?
Good. And what's basically the cousin of ulcerative colitis?
I'm sorry, what's the what?
Like cousin of ulcerative colitis, or the other inflammatory.
I'm sorry, I couldn't hear. Crohn's disease.
Good. All right. Do you have more? What else can cause rectal bleeding?
What about like a bad a bad infection, like an infectious process, like a
like some kind of enterocolitis, like E. coli can cause you to have
right.
blood. So you can have a really bad colitis. Good. All right. Let me go ahead and move on to someone else here. By the way, I'm going to start moving between the people that I know who spoke before. If you go ahead and you can type in the question, just like, hey, I can talk. All right. Danielle, I believe I called on you before, did I not?
Yes, you did.
Give me some.
I am going to the extreme, maybe rectal cancer, because he has a
No,
history.
that's great. It's like carcinoma. Rectal bleeding carcinoma. We should always think about that. What else?
If we did a rectal exam at all?
At the moment, no, but I will tell you the results based off of like what I'm doing for the case.
Okay, because I was like, oh, he could have like internal hemorrhoids or something, but I don't know. That wouldn't really cause the different colored blood in his stool.
What would cause melena though?
But bright red, I guess it could cause bright red bleeding too. Okay.
What causes the dark blood?
Mm-hmm.
What causes the dark blood? Where is the bleed if you have dark blood in your stool?
Oh, like in the esophagus, like an upper GI bleed.
Good. All right. I just saw a hand raised from Vankus. I'm going to go ahead and let him in. Do you have some for me?
I did. Can you hear me?
Yes, we can.
Oh, I did, but I feel like all of my differentials have now been taken. So I'll go ahead and lower my hand.
All right. Well, I'm going to keep you in because I'm going to ask you for some tests. But I mean, guys, what if this guy has a complete red herring? What if he has hemorrhoid bleeding, but he has a UTI, or he has a pyelonephritis, or he has a prostatitis? I mean, what if the two diagnoses are completely separate? He just happens to have hemorrhoids, or he potentially just has a lower GI bleed, but he has something completely different causing his abdominal pain. We should be able to think three-dimensionally in that sort of sense. But what sort of tests, Vankus, do you want for our patient?
We can start off with a CBC, a CMP, and a coag studies.
What would be a colitis study?
Oh, I said coag, so bleeding.
Oh,
So,
coags, INR, PT-INR. Good. All righty then. Good job. Jeff, I'm letting you back in. Jeff, what test do you want?
Sorry, I don't have a good answer here. Are there any kind of imaging studies we'd want to think about? I don't know if this is a case where.
Yep, CT abdomen would be good. CT abdomen could be a good place to start. You could also do an ultrasound if you wanted to. But if you're looking for diverticulitis, which is kind of our #1 diagnosis, he had it before, CT scans can be a little bit more beneficial for this guy. I mean, I'm going to go ahead and fill this out for everyone else. We can go ahead and get a urinalysis. What if he's just having, like I said, UTI, prostatitis, etc. We could also be getting, you could get things like a lactic acid. Although we did not mention pancreatitis, once again, what if he has hemorrhoids and he just happens to have pancreatitis? You can get a lipase level for him. The definitive one is going to be colonoscopy for this guy. Where is his bleeding coming from for him? So
Chris, Daniel asked, why would we say BMP rather than a CMP?
All right. Then I'm going to go ahead and ask the reverse question here to Danielle. Danielle, what is the difference between a BMP and a CMP?
The CMP also looks at like kidney and liver function.
Okay, you actually get a BMP actually gets you the function of the kidneys. You get creatinine and BUN, and that's actually going to be very important for this case, kind of. But here's a question for you: why do we need liver tests?
To rule out all our bases, or to cover our bases.
To practice defensive medicine. Not to call it that, but I mean, okay, fair. We can get a CMP. How's that?
Well, so normally in this case, you would order a BMP instead of a CMP.
No, you can order a CMP. You can order a CMP. Once again, you can look for organ dysfunction. What if you're losing enough blood that your liver enzymes are going up? What if this guy has a gallbladder thing going on? Totally fair. You know, we just didn't put it up in our diagnoses. What if he has cholecystitis and hemorrhoids? Boom. You know, so that'd be a good place to be. I just wanted to, you know, have you defend yourself, defend your decision. All right. So let's go ahead and look through our testing here. So first off, we got a CBC and a CMP. All right. So I'm going to go ahead and show you what we can get for our CBC and our CMP. All righty then. So I want you to take a look at the CBC here and take a look. I'm going to let Jasmine back in. What do we see here?
It looks like they are anemic. So their red blood cells, hemoglobin, hematocrit are low.
Yep. What kind of anemia is this? Have you been able to learn, you know, microcytic versus acute blood loss versus other kinds of anemia?
It looks like a normocytic, normochromic anemia, which is also, I guess, correlates to like an acute blood loss anemia.
Perfect. Good job. You did a great job. Maria, you can get a lactic acid because that can be very common. That can be used to rule out kind of infections. You see it a lot in belly stuff. It's also part of sepsis criteria. So lactic acid is a good thing to get to see if are we ruling out any kind of infection or, you know, how bad is the inflammatory process for our guy. All right. Next, let's go ahead and get a CMP here together. I apologize. I've got so many windows open. I've got so many monitors. Alrighty. Maria, I'm letting you back in. What do we see here in our CMP? At least for now.
It looks normal.
Yeah, and even down into the LFTs and things like that. Now, why is this important? You know why we get why we should get a CMP when we're concerned about GI bleeding?
Would it be is it a sepsis? For sepsis?
So it's actually, so I'm going to let you guys in on a great little trick here. So when you have an upper GI bleed, you get concerned about an upper GI bleed when you have black stool, because, you know, the stool is, you know, coagulated, ends up, the blood gets coagulated, it ends up in the stool, it's dark rather than bright red blood. Now, when you have someone come in with a GI bleed and you end up with melena or melanotic stool, how do you determine whether or not this person needs to get an endoscopy as well as a colonoscopy? Just find out where the bleeding is from. Well, one great way is to look at the BUN to creatinine ratio. So we see here that the BUN is 18 and the creatinine is 1, good normal levels to have. But when you're bleeding from the stomach, you digest that blood and you increase the amount of urea in your system. However, you do not usually become hypotensive enough to cause a reflex decrease in the kidney function. So you don't see the creatinine go up. So what you see is the BUN to creatinine ratio. If it's 35, you can basically call a gastroenterologist. You might see other numbers. You might see, you know, 30, you might see 36, et cetera. But if you kind of have a 35 BUN to creatinine ratio and you call a gastroenterologist or general surgeon and say, hey, I've got a guy with a GI bleed, they've got some melena, a BUN creatinine ratio of 35 or more, that's basically, yep, you're getting an endoscopy just to rule out gastritis, you know, gastric ulcer. So there is a reason to get BMP or CMPs in our patient with GI bleeding, is to look for that BUN to creatinine ratio. All right, Maria, do you mind if I pick on you for the rest of the labs?
No.
All right, perfect. All right, we've got some other things such as lipase. What do we see here?
No, lipase is normal.
Good. How about our PT and INR?
They're normal.
Good. Anything interesting in our urinalysis?
No.
Awesome. And last but not least, what about our lactic acid? Do we see anything significant here?
No.
Cool. All right. So what do we kind of end up with here? Out of all these labs, what are we thinking about? What's the number one thing that's sticking out to us?
Well, he's anemic. He's
All
losing
right.
blood.
It's that anemia. Fantastic. Good job. All righty then. All right, Danielle, I'm coming back to you. Based off of these lab values, we should now go back and look at our patient here and say, based off these lab values, what can we start taking away from our differentials before we kind of move towards a definitive test, which would be colonoscopy? And then, or CT. I'll show you a CT here in a second.
We could take out the hemorrhoids.
Yeah, let's say we got a, say we got a digital rectal exam. When I was in residency, we called it a DRE, or a diligent resident exam. And say that came back blood, but otherwise normal. So correct, a hemorrhoidal bleed shouldn't cause you to have like catastrophic bleeding that's causing you to have an anemia. Danielle, when do you want to transfuse this guy? What level do you want to transfuse this gentleman?
I'm not sure.
So in a cardiac patient, it's going to be 9 because they are at risk for blood loss, ischemia, whereas for other people, it's 7. So his anemia is around a 9. He has never had a heart attack in the past. It says he has angina, but we don't have a confirmed history of like, a stent or anything like that. So he would be at a 7. So he's not at transfusion level quite yet. Other diagnoses you want to take away from this guy?
It's not an infectious process, so we could also take out like the, diverticulitis.
You're right. I don't think this is bad diverticulitis. I personally don't.
Mm-hmm. And then it's not a UTI because his UA was clean. Not a pilo either, because I feel like his UA was fine. He would probably have like some bleeding, and his pain would be localized elsewhere, like in his upper back.
Yep.
Probably not prostatitis either.
Yeah, we can also probably take away prostatitis. So we're kind of left with upper GI bleed, ulcerative colitis, Crohn's, colitis, carcinoma, etc. All right, cool. So in terms of ulcerative colitis and Crohn's disease, are we terribly concerned with a 51-year-old male having a new onset autoimmune disease? It's kind of left field, it's kind of out there. But seeing as how we'll probably be getting a colonoscopy anyway, it's there. 51-year-old male, this guy's in the exact range for having his colonoscopy. So, carcinoma and colitis are totally, are completely valid. All right. So I'm going to go ahead and pull up my CT scan for our gentleman here. All right, I'm pulling Jeff back here into the room. By the way, if you guys want to chat, just like I said, put yourself into the Q&A and I can let you talk if you haven't talked yet. All right, Jeff, have you ever looked at a CT scan before? This is just a picture of one.
I have seen them, but haven't had any training on reading them.
All right, so what we can see here is, basically you've got kind of liver here, spleen up here, looks like stomach, you've got colon stuff going on. I'm not going to get too much into this. You've got the psoas muscle here. Kind of orient yourself. And I'm going to tell you right now that that we got a CT scan and we had a normal CT scan for our patient. So essentially unremarkable CT scan, no signs of perforation, no signs of infection, no signs of diverticulitis, etc. This would be a good scan to also do for something like appendicitis. You could have also picked up, our gallbladder pathology on here by looking over to see if there was any, stones or blockages there. You could have used ultrasound for either of those as well. This could have also picked up infection in the kidneys for pyelonephritis, etc. So CT scan would have been a great option for us to kind of start ruling everything out. However, Jeff, the question is did a normal CT scan change any of our possible diagnoses? Ulcerative colitis, Crohn's, infectious colitis, cancer, upper GI bleed. Did having a normal CT scan change any of that?
I don't know that it did compared to endoscopy, right?
Not at all. All right, cool. All right, who here, I'm gonna ask a question now. Who here wants to raise their hand and tell me if they've ever seen who has never seen a colonoscopy? Danielle, Heba. All right, cool. Well, I'm gonna go ahead and give you guys a bit of a treat here. All right, so first off, so our guy's pretty much hemodynamically stable. He's looking good. We don't have signs of infection because the last thing you want to do is stick a scope up someone who's having inflammation because you might cause a perforation. All right, so we get a scope. This is part of a normal colon. This is the transverse colon. It's very easy to remember, transverse triangle. Super easy to remember. That's how you know you're in that part of the colon. So you can see it's nice, smooth, nothing too crazy going on. All right. Does anyone here know the difference between diverticulosis and diverticulitis? Because he mentioned he had itis, and we've also heard the phrase diverticulosis. Someone raise your hand if you want to explain diverticulosis versus itis. All right. Venkus, you've just volunteered as tribute. What is the difference?
Involuntary tribute. So the itis would just be an inflammation, whereas diverticulosis is an outpouching or weakening of the tissue.
Exactly. So on colonoscopy, oh gosh. Diverticulosis on a colonoscopy is going to look more like this. You're going to get these little outpouchings. About 50% of adults in the United States have these. They're very common. They're usually due to low fiber, they're usually due to poor diet because you just increase the pressure so you form these little pockets. And it's these little pockets that get infected that leads to diverticulitis. The biggest thing for this guy is that, hey, these can also bleed. These about 80% of people, about 80% of people who have these will bleed at some point. Whether it's significant or insignificant bleeding is to be determined based on when are they going to bleed. But because he had diverticulitis, he must have diverticulosis. All right, so we get a scope and say that's what we see. We see just diverticulosis, but we don't necessarily see any kind of significant place for his bleeding. Now, what we didn't see is anything to biopsy. So there's no ulcerative colitis, no diverticulitis. We kind of ruled out other kinds of colitis. We didn't see a cancer. We kind of ruled out with our BUN to creatinine ratio, we didn't see anything, and we didn't see ulcerative colitis. And Venkus, we're out of diagnoses. What did this guy actually have?
So refresh my memory. So all we saw was the diverticulosis. We didn't see any actual source of bleeding.
We didn't necessarily see, any source of active bleeding, but we've ruled everything else out. What could this be?
You have stumped the chump. I don't know.
Right. So if it's not upper GI bleed, it's a lower GI bleed by definition. And the most common cause of lower GI bleed is diverticular bleeding. So whether or not you find it on the diverticuli with the bleeding, this is the most common cause of lower GI bleeding. Now, I'm going to kind of take over. So
sorry, one question though. So even if you don't see active bleeding, but you see the diverticulosis, you can just go on clinical presentation at that point.
Yeah, because colonoscopy can find the bleeding about 80 to 90% of the time, but every now and then you might not find
it. Okay, thank you.
All right. Now let me ask you. I'm going to put you on the spot one more time. All right,
sure.
We've got this guy who's bleeding. He's got a diverticular bleed. Most of the time, how do you want to manage a diverticular bleeding patient? What do you want to do for them?
Source control. So either banding, I guess.
So like banding, ligating, cauterizing, something like that?
Yeah.
All right, cool. Thank you very much. I'm going to go ahead and kind of take over for a little bit. So most of the time for a diverticular bleed, you've got more of, you're going to just treat it conservatively. You're not going to do anything. Most of them will self-resolve. There are guys I've had come in and they just bleed like crazy. And I've gone ahead and give them, like 4 or 5 PRBCs, units of blood, and eventually they just get better. We've done all kinds of scans on them. We couldn't find the bleeding. We just kind of kept pumping them with blood, hoping that they'll stop. Now, what happened? That works for most people with a diverticular bleed. What happens if you do not stop? Well, that's when you can go in, look for the cautery, try and stop the bleeding from that way. If you can't find that, you're left with partial colectomy. You just take out the part of the colon that's bleeding. How do you determine what part of the colon is bleeding? You can use a tagged red blood cell scan or nuclear scintigraphy. They're very sensitive, but they're not very specific. So they're really good at telling you that you have bleeding, but they have a fairly high, up to 60% false localization rate. So you kind of have to be very careful of making sure you're taking the right part of the colon out, that you're treating the right area, et cetera, et cetera. So let's kind of do a quick review of this. All right. So this patient came in with rectal bleeding and severe abdominal pain. All right. He said that he's been losing a lot of blood and he had a history of diverticulitis. So that should kind of be at the top of our list. Diverticulitis can definitely cause some bleeding, but also keep in mind some other things. He had some black stool. So we have to think, okay, is he having an upper GI bleed? And then just other abdominal pain things, pancreatitis. What if he has appendicitis, cholecystitis? What if he has hemorrhoids that are bleeding, but he actually has a pyelo, or his prostatitis, or his UTI? We're starting to look at that. Those diagnoses should jump into the front of your mind when you look at this patient. Sick, not sick, what are my diagnoses? Then you move forward and you start looking at vital signs. Okay, if he is bleeding, how unstable are his vital signs? They don't look that unstable. His blood pressure is a little low, but we don't have that reflex increase in his heart rate. So therefore, he's not losing enough blood for me to be concerned about. So we come up with our diagnoses. So we say, okay, I don't need to slap this guy with pressors. I don't need to slap this guy with blood or IV fluids at this moment. We move forward and we come down to all the different diagnoses we have. And we say, okay, what can we do? Well, we get CBC. Let's quantify the anemia. We saw that he had a normal cytic anemia, normal chromic, so more of an acute blood loss anemia. Great. Hasn't been around for a while, but also we can see, does he meet transfusion criteria? No, he didn't. CMP, well, we were concerned of an upper GI bleed. So we look at that BU into creatinine ratio. Remember, that number is going to be 35 or thereabouts. You'll see some numbers kind of in that range from different societies. PT and INR, well, he doesn't have any kind of coagulopathy. UA, lactic acid, lipase, all that stuff looked great. We got a CT abdomen pelvis. You might see diverticuli on CT abdomen. You might not. You can usually find a diverticulitis on a CT scan. We didn't see appendicitis. We didn't see other things going on. Colonoscopy just showed diverticulosis, and probably 80 to 90% of the time that colonoscopy could have found where the bleeding was and cauterized it. But what if it's really back there in a diverticuli and you couldn't find it? Well, most of the time they solve themselves, or you just have to cut the colon out. That's very rare. Vast majorities will solve themselves. So I did want to talk about the different kinds of GI bleeding. So only about 33% of GI bleeding patients are lower GI bleeding patients that come to the hospital. But we feel that's a very underreported number, because how many of us have found some blood on the toilet paper when we've gone number 2 and we didn't rush ourselves to the emergency room, right? Like, we feel this is a very underreported number, but that upper GI bleed presents to the hospital more frequently because, hey, I'm coughing up blood, or it's like blood's not supposed to come out of that way. I'm coughing up blood, or I'm vomiting blood. That prompts people to come to the emergency room far more often, go to the hospital. So we feel this is more of a perception of severity rather than an actual strict number of cases for people. When you end up with that upper GI bleeding scenario, you're going to want to look at hemodynamic stability. You're going to want to make sure that volume status is good. Looking at BU and creatinine ratio, it's like, okay, where's this blood coming from? With these lower GI bleeding patients, basically the same thing. You want to handle them the same way. You're looking at hemodynamic stability and trying to suss out where in the world this bleeding is coming from. Diverticular bleeding is the most common form of lower GI bleeding, but you might see angiodysplasia, fissures, ulcers, colitis, neoplasm, etc. All right. Now, this is a little bit of a different case because generally diverticular bleeding is going to be painless bleeding. And that's another reason why a lot of people don't present to the hospitals, that it's painless bleeding. This guy's final diagnosis wasn't actually a diverticular bleed. However, he presented so much like one aside from the abdominal pain. I wanted to kind of teach this as something you'll see far more commonly. This is a diverticular lower GI bleed is something you will definitely see, whereas this is far less common. So one thing we can look at is, what were their differentials and what were their thoughts? Abscess, appendicitis, proctitis, UTI, basically a lot of the same things we said. CT, CBC, lipase, PT. What was interesting about this guy is that he was actually diagnosed with acute proctitis with rectal bleeding. So proctitis is inflammation of a portion of the colon, and there are only two kinds of proctitis. Really, there's radiation-induced proctitis, for people who have had rectal cancer, and then you have gonorrheal proctitis from getting an STD. Now, his wife is in the room, which means that at some point during his past, or currently, he is having receptive anal sex of some form and obtained gonorrhea that way. That was most likely what happened for him, because he did not report any history of having radiation to his colon.
Well, another option, this case also, Chris, was this was a provisional diagnosis in the emergency department. That may not have been his definitive diagnosis, and I would be concerned with his history of melena that there was something else going on, and sometimes ED doctors don't always get it right for that provisional diagnosis, and so I would still be concerned that he had some sort of bleeding, some sort of upper GI bleeding, either from peptic ulcer disease, esophagitis, gastritis, and/or upper GI diverticulitis. I still would be concerned a little bit about that.
Absolutely. Now, let me put it this way. Just because, remember, you have to look at patients, not lab values. Just because a BO to creatinine ratio can be normal, I made this normal for the purposes of saying, hey, I want to lead you down the path of a lower GI bleed, purposely. That being said, if you're convinced that this patient has an upper GI bleed, talk to who you're curbsiding, talk to your consultant and say, I'm concerned this patient has an upper GI bleed. And with a normal BO to creatinine ratio with that amount, you can still scope them with good history. Remember, about 80% of histories of diagnoses are made off of history alone. We are very good at diagnosing based off of just what the patient tells us and our training. All right.
It's funny you say that, because I work with learners still, and when I have an outstanding learner working with me, giving me outstanding histories and outstanding presentations, I almost know what the diagnosis is the vast majority of time, and I don't even see the patient, because they can describe exactly what's happening. Being an accurate historian is so important. 80 to 90% of the time, the history can lead to a diagnosis. Absolutely correct.
Yeah, and that's not a number we're pulling out of our hat. That's actually a verified statistic study that they've actually looked back on thousands of cases and many different providers. All right. I see here in the QA. How do you diagnose proctitis? Yeah, you kind of you can do an STD test back there. You take a swab back in there. But other than that, that's basically the case. The points I really wanted you to take away is being able to differentiate. When I look at that stool, bright red blood, if there's melena, lower and upper, what different lab values can I look at? BU into creatinine, coagulopathies, etc. But what are our most common causes of having GI bleeding? Most commonly that you will see is upper, but what's probably happening out in the community is most likely lower. And the most common cause of lower GI bleeding is diverticular, painless, and handled conservatively. But that's basically the entire case and some of the lessons I wanted to leave you guys. We've got a couple minutes. Does anyone have any questions I can answer right now?
While we're waiting for that, I just want to thank you so much. I want to say that this is the first time I was able to watch you teach an entire session, and you're an awesome educator. And we're so incredibly fortunate to have had you present a real patient, ReelDx case today. And for any of you on the call today, would love any feedback that you could send us around this experience. But the opportunity here is to present these ReelDx real patient cases for those of you that are learners or wanting to learn more, and create a learning opportunity for you all today. So I'm appreciative of all of you who attended. I'm especially appreciative for all of you that were willing to chat and speak. And I'm incredibly appreciative of Chris for his time today and for preparing for this and his outstanding education around this case.
All right,
So
I don't see any other questions.
I think Danielle had one question, which was, why did you choose to get Dilaudid for pain rather than another narcotic?
I was not in the ER. I was not the one who decided to do this one, but I mean, you know, you could just dose it. Remember, it's like, I think it's 1 to 3 or 1 to 4.
Yeah, I think it's a preference choice. I think some people get very comfortable using one or the other. As a peds ER physician, I'm very comfortable using fentanyl and morphine. I use less Dilaudid in the pediatric ER, but I think that it's somewhat splitting hairs. Fentanyl is very rapid onset and very rapid offset. And oftentimes with fentanyl, you need to dose a little bit more frequently than morphine. I'm very comfortable with weight-based dosing for both, especially with morphine. And typically for children that present with severe pain, I often use morphine in the peds ED. But Danielle, that was a great question. And with that, we will say have a great rest of the morning or early afternoon if you're on the East Coast, and have a great day. Thank you all for joining. Thanks, Chris.
Take care, y'all.
Thank you.